Greetings, my name is John Embil, and on behalf of my co-authors, I would like to present to you the key details from the Diabetes Canada 2018 Clinical Practice Guidelines, Foot Care, Chapter 32. There are a number of key changes in the 2018 guidelines. Of note, new information is provided on the use of the 10-gram monofilament in detail so as to assist you with screening for the presence or absence of protective sensation. There is a foot care checklist, and some of the key factors are: educate your patient about proper foot care, examine the foot for structural, vascular, and neuropathic problems, perform a 10-gram monofilament assessment, and of course identify those at high risk of foot ulcers and educate those individuals about foot care and foot wear. And of course, if an individual has foot ulcers, please refer them to an appropriate provider for specialized foot care and appropriate footwear. When we consider this graph from the Public Health Agency of Canada, you will observe that lower limb amputations for persons with diabetes are a very significant issue. Let's consider foot complications in persons with diabetes in the context of prevention through education, appropriate risk assessment, and of course early and aggressive treatment. Let's consider the do's of proper foot care for persons with diabetes. The first thing that must be done is the feet must be evaluated every day for cuts, cracks, bruises, blisters, ulcerations, infections, or any other unusual marks which could be a manifestation of trauma, which could have deeper consequences. If the feet can't be evaluated directly, a mirror can be used to see the bottom of the feet, or alternatively, someone, either a family member, a friend, or another caregiver, can review the feet directly. Check for the color of the feet. This could be a warning sign for infections or other problems. If there's swelling, warmth or redness, or pain, this should be a warning sign that brings the patient to a caregiver. The feet should be washed and dried every day, especially dry between the toes so excessive moisture does not accumulate, leading to maceration of the tissues, period. Skin lotion or a moisturizer should be applied to the feet every day to keep the skin supple, period. Excessive lotion or cream should be removed, as this can lead to maceration. The socks should be clean and dry and changed ideally every day. The nails should be trimmed straight across. This will minimize chances of ingrowing nails. Clean cuts and scratches with soap and water and cover with a dry dressing, if necessary. Wear appropriate footwear that is professionally fit and minimize heels. Footwear should be purchased later in the day to accommodate for increasing swelling over the course of the day. Avoid extreme heat and extreme cold, and of course, if a foot problem ensues, or for advice alone, consult with a specialist knowledgeable in foot care. With regards to the don'ts in foot care, do not cut calluses or corns with razors or scissors. For these matters, please see a specialist in foot care. Avoid over-the-counter medications for corns and warts. Do not apply heat with a water bottle or electric blanket. These may cause burns that can go undetected. Avoid soaking the feet or using lotion between the toes. It is important not to soak the feet, as this can lead to excessive moisture and ultimately drying of the feet. Avoid taking hot baths. This may lead to scalds and burns. Avoid walking barefoot, both inside and outside, as this can lead to undetected foot trauma. Avoid wearing tight stockings, garters, or elastics, unless otherwise indicated by a healthcare provider. Avoid wearing over-the-counter insoles. These may lead to undetected trauma, such as blisters. And avoid sitting for prolonged periods of time, as this can cause significant leg edema. And of course, a very important don't is don't smoke, or alternatively, make efforts to quit smoking. How to perform the proper foot examination? There are some key factors that we need to consider, specifically either structural deformities or abnormalities, what is the status of the peripheral vasculature, and how is sensation? With regards to structural abnormalities, we want to evaluate the skin, looking for evidence of infection, breaks in the skin, calluses, cracks, ulcerations. What is the range of motion of the feet? And are there structural deformities, such as those compatible with Charcot arthropathy? With regards to peripheral vascular assessment, we want to evaluate for the temperature of the feet, whether there are any changes compatible with peripheral vascular disease, and, if available, perform ankle brachial blood pressure indices or have those studies performed. And of course, in terms of assessments for neuropathy, the 10-gram monofilament is the key instrument to help guide us as to whether protective sensation is present or absent. This table demonstrates key elements of the lower extremity physical examination, specifically inspection. With regards to inspection, what is the patient's gait, or do they ambulate? Are they using assisted devices? When we consider foot morphology, are there bony prominences or changes compatible with Charcot arthropathy? In addition, what is the toe morphology? Are there claw toes or hammer toes, and what is the number of toes? With regards to the skin, are there blisters, abrasions, calluses, subkeratotic hematomas, or hemorrhages? Are there ulcers? Is there absence of hair? Are there any nail issues? Specifically, are there ingrowing nails? Is there lower extremity edema? What is the color of the skin? Is it ghostly white, or is there evidence of dependent rubor? What is the status of the nails? This is very important, as long, unkept nails can lead to trauma to the soft tissues. And is there ingrowing of the nails? Foot hygiene is very important to document and provide guidance for the patient. Specifically, are the feet clean? Is there debris between the toes? Is there evidence of tinea pedis? With regards to evaluation of peripheral vasculature, let's palpate for peripheral pulses and get a sense of the temperature. Protective sensation is a vital part of the physical examination. Is protective sensation intact? For evaluation of protective sensation, the 10-gram monofilament is of immense value. With regards to the footwear, this is also a key part of the physical examination. What is the status of the footwear? Is it appropriate? Is it inappropriate? Does it show signs of extensive and excessive wear? Are there foreign bodies and penetrations through the outsole? Are there orthotics? Are there foreign bodies? And are there signs of wear on the interior of the shoe? With regards to evaluation of protective sensation, the simplest technique is shown here from the International Working Group on the diabetic foot. You will note that to get a very crude sense of whether protective sensation is present or absent, we can use the 10-gram monofilament in the toe pads of the great toe and first and fifth metatarsal heads. If protective sensation is absent in any of these locations, this should be a very strong warning that the patient is at risk of foot complications from diabetes. This slide shows how to screen for the presence or absence of protective sensation using the 10-gram monofilament. Before applying the monofilament to the feet, apply it to the cheek or forehead and ask the person with diabetes to report whether they can appreciate the monofilament. If they do, then they know for what they should be vigilant when the monofilament is applied to the feet. To apply the monofilament to the feet, use sufficient pressure to cause it to buckle. This will solicit or elicit the sensory threshold, and then apply the monofilament to the metatarsal heads and toe pads. Ask the person with diabetes to report whether they appreciated the monofilament applied to the feet. If they do, then sensation is preserved. If they do not, Then concern is raised about the absence of protective sensation. Who is at high risk of developing a foot ulcer? Anyone with peripheral neuropathy. This was evaluated in the last slide using the 10-gram monofilament. The monofilament should be a key staple of anyone's lab coat pocket. Anyone with a previous ulceration or amputation is at risk of developing a neuropathic ulcer. And anyone with a structural deformity or limited joint movement is also at risk. In addition, those with lack of protective sensation and peripheral arterial disease or those with other microvascular complications are at risk. In addition, having an elevated hemoglobin A1C is a risk, as is onychogryphosis. When should a foot examination be performed? In individuals who have preserved sensation, perform the examination annually. With those at higher risk of a foot ulceration, perform the review every 3 to 6 months. And in those with a foot ulcer present, this individual should be referred to someone with expertise in the management of neuropathic foot ulcers. With regards to the foot ulcer, how should we manage this? What is the interprofessional team approach? For individuals at high risk of a foot ulceration, there should be foot care education and appropriately fitted orthopedic footwear with custom molded orthotics. If an ulceration develops, however, prompt referral to a team with expertise in the management of foot ulcers is of vital importance. When we consider the University of Texas Diabetic Wound Classification Scheme, we consider stages: those individuals with no infection and no ischemia, and those individuals with infection and ischemia. The table nicely summarizes the key issues. With regards to the recommendations from the foot care chapter, the first recommendation is that healthcare providers should perform foot examinations to identify persons with diabetes at risk of ulceration and lower extremity amputation. At more frequent intervals in high-risk persons, the examination should include the following elements: an assessment for neuropathy, an assessment for status of skin, an evaluation for the presence or absence of peripheral arterial disease, and an assessment for structural abnormalities. The second recommendation is that people with diabetes who are at high risk of developing foot ulcers should receive foot care education, including counseling to avoid foot trauma and obtain appropriately fitted orthopedic footwear. When foot complications occur, early referral to a healthcare professional trained in foot care is recommended. The third recommendation is that persons with diabetes who develop foot ulcerations or show signs of infection, even in the absence of pain, should be treated promptly by an interprofessional healthcare team when available. This team should have expertise in the treatment of foot ulcers to prevent recurring foot ulcers and amputation. The fourth recommendation is that there is insufficient evidence to recommend any specific dressing type for diabetic foot ulcerations. Debridement of non-viable tissue and the principles of moist wound healing are of vital importance. In addition, offloading is critical to healing and preventing future ulceration. With regards to the fifth recommendation, there is insufficient evidence to recommend the routine use of adjunctive wound healing therapies, such as topical growth factors, granulocyte colony stimulating factors, or dermal substitutes for treating the typical diabetic foot wound. Provided that all other modifiable factors, such as pressure offloading, control of infection, and foot deformity, have been addressed, adjunctive wound healing therapies may be considered for non-healing, non-ischemic wounds, but this should only be undertaken in conjunction with someone knowledgeable of the condition and these products. So what are the key messages? Firstly, in persons with diabetes, lower extremity complications are a major cause of morbidity and mortality. The treatment of foot ulcers in persons who have diabetes requires an interprofessional approach that addresses glycemic control, infection, offloading of high pressure areas, lower extremity vascular status, and local wound care. Antibiotic therapy is not required for uninfected neuropathic foot ulcers. Proprietary adjunctive wound dressings and technologies, including antimicrobial dressings, lack sufficient evidence to support their routine use in the treatment of neuropathic ulcers. The key messages for people with diabetes are as follows. Diabetes can cause nerve damage, also known as diabetic peripheral neuropathy, and poor blood flow or circulation to the legs and feet, also known as peripheral vascular disease or peripheral arterial disease. As a result of neuropathy, people with diabetes are less likely to feel foot injury, such as a blister, or penetration, such as a puncture or a cut. Diabetes can also make these injuries more difficult to heal. Unnoticed and untreated, even small foot injuries can quickly become infected, potentially leading to serious complications. A good daily foot care routine will help keep your feet healthy. Examine your feet and legs daily. Care for your nails regularly or have someone care for them for you. Apply moisturizing lotion if your feet are dry. In particular, avoid lotion between the toes and massage the product well into the skin. Minimize residue. Wear properly fitted footwear. And test your bath water with your hand or elbow before you step in to ensure that the water is not too hot, as water that is too hot in a person lacking protective sensation could lead to scalds. Do not treat any of the following yourself. Rather, have someone knowledgeable in foot care provide assistance. Specifically, avoid treating calluses, corns, ingrown toenails, warts, splinters, and other wounds. If you have any swelling, warmth, redness, or pain in your feet or legs, see your healthcare provider or foot care specialist right away. Please visit guidelines.diabetes.ca for additional information and the rest of the guidelines. Or download the app, as shown here. Diabetes Canada Clinical Practice Guidelines can be found at the following locations.